Today I wanted to bring some light of what a pelvic floor therapist does, or women's health physiotherapist, what we do. And sometimes we have referrals from gynecologists or your general practitioner, other healthcare providers, and they're not given the heads up of what a pelvic floor therapist does. Sometimes they come in, they think that we're going to just look on the external musculature. But if you have problems with incontinence, whether it's bowel or bladder, if you have pelvic pain, if you've had a baby and there's tears, if you feel like there's numbness, there's things going wrong with your pelvic floor, it's best if we can do a pelvic floor exam. Now, having said that, you always have the option of declining an exam. You might not want it that session, you might not ever want it, and you have the right to say that. So it's always a dialogue. We always trying to explain what we do in a session so that you have information, we get informed consent. But when women that I see and we do a pelvic floor exam, they're often very surprised of how much they learn. They learn about strategies on improving their pelvic floor health. They learn why they have those symptoms that they're experiencing, what the treatment plan is going to look like, and it's usually a really great session with them. I really enjoy working with women and educating them on their pelvic floor health. So what happens? You come into the clinic, you come into the office, and when you're in the room, we have a chat and discuss what your symptoms are, and then I give what I think about what type of assessment we should do. And if it doesn't involve an internal exam, you would take off the pants and underwear and you lay on the bed and you're draped, and I come back in and then we make sure everything is ready and we're all good. And then I gently go into the pelvic floor to assess what's happening. Usually first thing I do is check with the tissues at the entrance of the vagina and see whether there's a lot of tone and it's painful there. Sometimes when we're in perimenopause or in menopause, these tissues can dry out a little bit and it can be tender and sore, and so that's already giving us information. I'm also looking at the vulva and making sure that there's no redness. So if there's incontinence, sometimes we have tissue breakdown. So I'm looking at the entrance of the vagina and I'm thinking, okay, is it red here? Is there what's called lichen sclerosis, where there's some whitening of the tissue? So I'm checking to see what the tissue looks like first, and then I go into the vagina and I am feeling what that first superficial layer, that first entrance layer is like, what the tone is like, if it's really tight or is it pretty good, if there's some scar tissue in there from having babies. Then we check into the intermediate layer, and then I just do a sweep and check the deep layer muscle and just checking tone. And then we have a look to see whether there's prolapse. So do you have an anterior wall prolapse? Do you have a posterior wall prolapse? Do you have an apical prolapse? So we check to see what prolapse you have and have a discussion about that. And then we have a look at your strength. So we're going to look at the function of your pelvic floor. We have a look at power, so your strength. We have a look at the endurance. We're going to see the quality of contraction. How do you contract? Are you stronger on one side than the other? Which usually surprises my clients. But just like the muscles on the outside can have one stronger hip or one tighter hip, the muscles on the inside can be the same too. So they don't always work exactly the same. In fact, I usually find that some areas are not as strong as other areas on the opposite side. We're having a look to see whether there has been any disruption of the muscle, whether there's a bit of a divot because the muscle has been torn internally from childbirth. And we gather all that information, creating a treatment plan for you. Sometimes it involves Kegels, sometimes it does not. If you're tight, we tend to not do Kegels. But I always say we don't want to throw the baby out with the bathwater. Right now there's a big trend towards doing a lot of breath work and hip stretches because we're not dealing with tight week. So oftentimes we'll be tight inside, and so that's where you would use a pelvic wand, or I go in and I start releasing the muscles of the pelvic floor so that they are a little less tight, and then we can have more strength, because a tight muscle is never a strong muscle. So if your shoulders are up near your ears, it's not strong, it's just tight. And it's surprising, probably about 1 in 4 women actually have a tight pelvic floor. So, and even women who don't have a particularly tight pelvic floor, but maybe they have had a fall onto their bottom and some of the areas have gotten tight, or maybe you've had a baby and had a hard push or some type of intervention like forceps, and then that bit of muscle has tightened up. So we'll go in and we'll just do some trigger point releases. All we can do is use our finger, and we'll go into that tight area and press on the knots until they release. And then as you do that, instead of having a tight muscle, the muscle starts to relax back down, and then you have a nice, fully functioning, strong pelvic muscle again. I hope that has clarified what we do as a pelvic floor physiotherapist. And if you do go to a pelvic floor physiotherapist and you're not offered a pelvic floor exam, do check in with them and ask them, hey, I'm open to having a pelvic floor exam today. Could we check my pelvic floor? Because it's important that when you've gotten up the courage and you're like, okay, I'm ready to go. I've washed up. I'm ready. I'm here. And some of my clients have been disappointed when they've gone to a therapist and they're not offered the option of doing an exam, and that's what they really had gone to the pelvic floor therapist for. Okay, good luck with everything, and I hope that's helped you out.